I'm Dr. Keshav Malhotra. I'm the lab director of Rainbow IVF, and today we're going to be discussing a little bit about pre-implantation genetic testing and the basic embryological aspects of this particular technology. Now, we know that pre-implantation genetic testing has become a tool to basically prioritize embryos for transfer, to select embryos for transfer. Mainly looking at some of the publications, people feel that pre-implantation genetic testing can help in improving clinical pregnancy rate, help in improving live birth rate, help in reducing the miscarriage rate, etc. Now, we will go on to the various publications that are there talking about all of these conflicting ideologies, but let's first try and understand what this technology basically is. So when I talk about pre-implantation genetic testing, it generally involves an IVF cycle. Now here it is preferred that the patient undergoes insemination using ICSI, but it's not a major mandatory factor. It's a preferred modality of insemination, and ultimately what we want to do is grow the embryos till blastocyst stage, and at the stage of the blastocyst we want to take out a few cells and then send it for genetic analysis, thinking that those few cells will give us some sort of a genetic representation of the growing embryo. Now, this technology has evolved quite a bit, and I'll just take you through all the different modalities of embryo biopsy and how the technology has evolved, what are the different pros and cons of each and every procedure. So the first thing that was developed, and this was way back in the 1990s, was polar body biopsy. And as you can look in the video right now, basically a polar body biopsy involves taking out either one or both the polar bodies and then sending it for genetic analysis. So using a laser, what we generally do is create a breach right next to the polar body, and then using a biopsy pipette, which is very small in size, we will aspirate the polar body and then send it for analysis. Now this particular technology has benefits in the sense that it is less invasive. It's not really touching on the part of the embryo that's going to become the fetus itself and still giving you some sort of genetic information. But that's also its major con, in the sense that we can only assess the maternal component for we can only test the maternal component. We don't really test the genetic component. So if there is any disorder that is coming from the maternal side, you can basically identify it, but that's pretty much it. You still can get a confirmatory diagnosis using a blastocyst biopsy, but that's pretty much it, right? There are two techniques of doing a polar body biopsy. First is the single polar body biopsy approach, where you only take out the second polar body, and the other one is a day 0 and day 1 approach, where both the polar bodies are taken. It does require a little bit of skill. It also requires a little bit of luck, because there would be times where the polar body is fragmented, and in those scenarios doing this becomes very, very challenging for us. Another advantage of a polar body biopsy is basically you don't require freezing the embryos. You can still do a fresh transfer, and that also ultimately reduces the cost towards the patient. Coming to the next type of embryo biopsy, and this is basically a cleavage stage biopsy. This is done on day 3, or when the embryo achieves a 8-cell status. Now, when you have an 8-cell embryo, the biggest advantage that we are getting is that the embryonic genome switches on. So it's a good stage to start thinking about genetic analysis, even though it's not the best, and we'll talk about it. It's a good stage. At least it's better than the polar body. And what we do in such a scenario is that we take out one cell or a maximum of 2 cells. Now 2 cells is pushing it a little too far, but sometimes you can take out 2 cells. But we at least take out one cell with an intact nucleus and then use it for genetic analysis. Fairly simple. What we try to do, as you can see in the video right now, is then create a breach in the zona pellucida using a laser. Using a larger bore pipette now, we are going to aspirate one of the blastomeres. And the important aspect here is that you have to first visualize which blastomere that you want to take out. This visualization basically focuses on the nucleus of the blastomere. and then position the embryo in such a way that that blastomere is accessible, and then you just aspirate that blastomere out like you could see in the video right now. You would require a laser for this. You would also require a lot of skill. And again, if you have an in-house laboratory, you can still have a good turnaround time and do a fresh transfer. But the major problems with this technique is that we still are not sure whether that one cell is the correct representation of the embryo or not. Because looking at just one cell, we can't really figure out whether it will be a mosaic, whether it will be aneuploid, whether it will be euploid. Because if you look at the concept of mosaicism, we have different cell lines growing within the embryo at the same time, where some of the cells could be aneuploid, but the majority of the embryo could still be euploid, and that will still be classified as a euploid embryo or a genetically normal embryo. Now, in such a scenario, when I'm only taking out one cell, if I'm taking out the aneuploid cell, which is not going to grow further, I am getting a false positive result, which ultimately means that I'm going to discard this embryo. And the patient is going to lose out on one more embryo which could have been transferred. That is the biggest challenge with a day 3 biopsy, and that's one of the reasons why it's not done anymore in any of the laboratories. People have definitely shifted towards blastocyst biopsy. Now, an intermediate between a day 3 biopsy and a blastocyst biopsy is a morula biopsy. This is done on day 4. This is done using calcium magnesium free media. So when when an embryo compacts, basically you can't make out how many cells are there. It's just a ball-like structure. So in order to do a biopsy on this particular day, we would want to decompact the embryo. And that's where we use a calcium magnesium free media, which ultimately decompacts the embryo, and you will get around 16 cells on this particular stage. And out of these 16 cells, you can easily take out 2 or 3 and then do a genetic analysis, and hopefully, again, if you have a genetic laboratory of your own, have a good turnaround time to do a fresh transfer in order to reduce on the cost. How do we do it? You can see it in the video right here. But generally what happens is that we will hold the embryo, we will create a breach at 6 o'clock position, which is below, and then just gently apply pressure from top, and you could easily take out about 2 to 3 blastomeres in such a way. Very easy to do, fairly simple, and does help us in maybe ruling out or at least commenting on mosaicism to begin with. But in order to get a diagnostic report on mosaicism, we have to do a blastocyst biopsy, and we generally need about 5 to 10 cells for analysis, and that's when we would be able to comment on the percentage of mosaicism that's present within the embryo. So like I mentioned, you would take out about 5 to 10 cells from a growing blastocyst. Now generally what we now prefer is that we hash the blastocyst on the same day and then aspirate a few cells, like you can again see in the video. And once you have about 5 to 10 cells, using a laser, you will just try and detach these 5 to 10 cells from the blastocyst itself and then send it for genetic analysis. There are multiple ways of doing the biopsy itself, and one of the methods is a pull method, which you're seeing right now, where we just shoot the laser at the junction of the trophectoderm and then just pull it gently using the biopsy pipette. The other method is the flick method, and in that scenario, I'll show you a video of that as well. In that scenario, what we do is that we will cut the cells using the holding and the biopsy pipette itself. So you'll just place the pipettes one over the other and then just cut the cells by doing one flick. Seems to be traumatic, but it's actually very clean and results in a very, very good sample for testing. So any of the methods that you prefer can actually be utilized for embryo biopsy, and samples from this can be sent for genetic analysis. Now we have to understand that there is no correlation between morphology and genetic testing or genetic composition. Even good quality blastocysts, being let's say 4AA, 5AA, can still be aneuploid, and even poor looking blastocysts can come out to be euploid. So in such a scenario, we have to understand that when we are choosing an embryo based solely on morphology, it might not be the best way of selecting an embryo for transfer. Does PGT bridge that gap? It actually doesn't. Based on all of the meta-analysis that we have, we know for certain now that preimplantation genetic testing for aneuploidies or PGT-A does not increase live birth rates. What it does is that it reduces time to pregnancy. And that could be one important factor, especially for our Indian population or the population of our subcontinent. Because here patients are paying out of pocket. They want to achieve a pregnancy in the shortest amount of time with the least amount of cycles. And in such scenarios, PGT-A is something that can be utilized. But whenever we are utilizing this technology, we have to make sure that an informed consent is taken from the patient, and this consent should cover the risks of utilizing this technology, should cover the benefits or the lack of benefits of utilizing this technology, and should also cover the indications of utilizing this technology. Once you have explained all of these to the patient and the patient agrees for it, I feel that would be an adequate way of proceeding with a PGT-A cycle for your patients. Now, ESHRE has come up with good practice recommendations for preimplantation genetic testing, and I think it's a series of 4 publications which talk about the genetic laboratories, which talk about clinical factors, which talk about embryology laboratories, and the different statements that are there. And these are good guidelines to follow, especially as a starting point for all of you to start knowing about preimplantation genetic testing, whether your laboratory can basically utilize this technology or not. And for like, if I give you a small example of these consensus statements, basically when I look at the guidelines, it states that you need a skilled embryologist to do an embryo biopsy, you need high blastulation rates, you need high pregnancy rates, you need a very strong and a very robust cryopreservation system, you need access to genetic counseling, and you should also have a demand for preimplantation genetic testing within your clinic. Then only you should be able to, then only you should think of actually starting a PGT program within your laboratory. So this was just a very small example. You can go through these consensus papers, and I'm sure you'll get the reference for it. And the Indian Society of Assisted Reproduction also has come up with a guideline or a consensus statement of for preimplantation genetic testing. And the unique thing about those guidelines are that it tells you everything that you need to do for a PGT cycle. It tells you how to utilize euploid embryos, what to do with mosaic embryos, what to do with aneuploid embryos. And these are certain things that, especially for beginners, you would need references for these particular questions. If you have any more questions, I would be happy to answer them. You can shoot an email to me. My email is mentioned here, and also links to my social media are mentioned here. Or you can contact the Shivani team at EART, and you can email it to them, and I can also help correspond through that channel. So thank you so much, and looking forward to your deliberations now.